Um, Mr. Gomari Sankar, 22-year-old male, who is a construction worker residing at Sankar Kovil and studied up to 10th standard, came to the OPD with a chief complaint of vomiting of blood for 1 day. History of presenting illness. The patient was apparently well before 13/12/2024. Then he presented with one episode of vomiting of blood without nausea. The vomited blood was initially coffee colored, followed by red blood, amounting to 100 ml without any ingested food, without any ingested food particle. History of black tarry stools for 4 days following vomiting of blood. No history of abdominal pain or distension. No history of epigastric pain associated with the food intake. No history of NSAID or steroid intake. No history of yellowish discoloration of skin. No history of heavy alcohol intake or retching before vomiting. No history of recent trauma, burns or sepsis. No history of loss of weight or loss of appetite. No history of fever. No history of frothy urine, facial puffiness. No history of cough or dyspnea. Past history, he had similar complaints 5 months back where he had one episode of vomiting of blood which was treated in nearby hospital and the blood transfusion was done. Not a known case of diabetes mellitus, hypertension, dyslipidemia, asthma and tuberculosis. Treatment history, medical treatment taken 1 month following previous hematemesis episode. Family history, no similar complaints in the family, no history of jaundice in family members. Personal history, non-vegetarian diet, normal sleep and appetite, normal bowel and bladder habits, no history of smoking, alcohol or substance abuse. Summary, a 22-year-old male with no significant personal or family history, presented with one episode of hematemesis amounting to 100 ml blood, followed by melena for 4 days. He had past history of similar hematemesis 5 months back, for which he got medical treatment and blood transfusion. The involved system is gastrointestinal.
He is conscious, cooperative, oriented to time, place and person. He is moderately built and nourished. Pallor was present, icterus was present, there was no clubbing, cyanosis, lymphadenopathy or edema. His height was 167 cm, weight was 61 kg, so the BMI was 21.8 kg per meter square, normal. On head to foot examination, there was no alopecia. I showed pallor, icterus and achalasia ring on both eyes. After seeing this, the father was also examined and found to have KFA. There was no white dot spots or subconjunctival hemorrhage or cataract or xanthelasma. The face showed no loss of facial hair or bilateral parotid enlargement. The chest showed no spidernalia, gynecomastia or breast atrophy or loss of axillary or pectoral hair or dilated veins. The hand showed yellowish discoloration of both the palms. There was no clubbing, pituitary contraction or leukomachia or tremor or blue nail. There was no abdominal distension or dilated veins. There was no atrophy of testes or pubic loss of hair. There was no pedal edema on both ends. The pulse was 64 beats per minute, normal in rhythm, volume, character, vessel thickness was normal. There was no radiofemoral delay. All peripheral pulses were held. The blood pressure was 120/60 mmHg in right upper limb on sitting position and 128/60 at standing. The respiratory rate was 15 breaths per minute. The temperature was 98 degree Fahrenheit. JVP was 3 cm elevated from the sternal ankle. It was normal. On examining the oral cavity, there was no bleeding gum or ulcer or petechiae on palate or mucosa. There was no glossitis, cheilitis or angiostomatitis. There was no fetal hepaticus. On inspection of abdomen, the shape was flat, the umbilicus was central and inverted. All quadrants moved equally with respiration. There was no visible mass or peristaltic movement or pulsation. There was no dilated vessel with veins, scars, sinuses or striae. Hernial orifices appeared to be normal. External genitalia was also normal. On palpation, superficial palpation, there was no local raising temperature or tenderness. On deep palpation, there was no guarding or rigidity or rebound tenderness, but liver was swelled 3 cm below right costal margin in mid-clavicular line. It was non-tender, soft in consistency, smooth surface and rounded margin. Spleen was felt 13 cm below left costal margin at mid-clavicular line. Smooth surface, firm in consistency, sharp margin, not tender. On percussion, liver dullness was the upper border of liver was obtained at the right with the intercostal space. Lower border was at 3 cm below the right costal margin at mid-clavicular line. The liver span was 13 cm. The splenic dullness was felt at the 8th, 9th and 10th intercostal spaces. There was no shifting dullness. On auscultation, there was a normal bowel sound and there was no splenic rub or fluid. On serious examination, S1, S2 was heard, no ardent sound or murmur. A venous hump heard at root of neck on right side on sitting position. Respiratory system, a normal vesicular bed sound heard on both sides. The CNS showed no vocal neurological deficit or no change in tone dystonias. Summary, a 24-year-old male patient presented with complaints of one episode of hematemesis amounting to 100 ml.
What are the differential diagnosis for this patient? Anemia, jaundice, forget about this KFL, right? Anemia, jaundice, hepatosplenomegaly, and especially massive splenomegaly. CML. Okay. Then, pick up 4 or 5 differential diagnoses for this patient. Need inform us? So usually what are the differential diagnoses for hepatosplenomegaly? Hepatosplenomegaly with anemia. Hepatosplenomegaly with the jaundice. Right? So hepatosplenomegaly with anemia. What are the differential diagnoses? Okay, leukemia. Hematological malignancies. That may be the first possibility. Okay, then. So you can do infectious cause, non-infectious cause. So infectious cause, malaria, right? Chronic malaria, not acute malaria. Chronic malaria, Kala-azar. Any other thing? Leptospirosis. Okay, accepted. Anything else? Common disease in our sector, common infection, tuberculosis, disseminated tuberculosis. So disseminated tuberculosis, even enteric fever. So enteric fever, malaria, associated Kala-azar, disseminated tuberculosis, leptospirosis. You have differential diagnosis if it is a case of anemia with hepatosplenomegaly. So jaundice with hepatosplenomegaly, chronic liver disease, very good. Viral hepatitis, chronic liver disease like cirrhosis. Okay, then infectious, again leptospirosis, disseminated tuberculosis, and then bacterial malformation, portal vein thrombosis, and then hematological pregnancies. These are the general discussion. Coming to your case, this is a young child. So young male with anemia, with the jaundice and hepatosplenomegaly. And how is the consistency of the spleen or consistency of the liver?
This patient had a soft liver and firm spleen.
Okay. So, infectious or non-infectious?
It could be infectious.
Okay. Now proceed. If infectious, pick out some particular illness.
It could be due to malaria.
So chronic malaria. It can be case of chronic malaria. Can you get jaundice in a case of malaria? How? Hemolysis. Right, recurrent hemolysis can lead to jaundice. Okay. Anemia. What are the causes of anemia in malaria? What is the mechanism? Premature destruction of RBC. Right, infected RBCs are lyse by the spleen. Okay. And then ineffective erythropoiesis also. Then nutrition deficiency. These are the causes, mechanism of anemia in malaria. So anemia may be common and the jaundices may be common. So this case can be a case of chronic malaria. That may be one of the differential diagnoses. Then coming to the second infectious disease, can it be a case of disseminated tuberculosis?
did not have history of cough or evening rest.
So leave out history. We are in a short case.
He did not have lymphadenopathy.
Very good.
And
So there will be generalized significant lymphadenopathy. At least cervical lymphadenopathy should be there. Okay. And then emaciation should be there. Emaciation. Anemia is already there. Same. What is the BMI? Is it normal or abnormal? Normal. Only let's say emaciation. Less than 18. Okay. Right. So it is somewhat normal. Right. So it can it be case of tuberculosis or not? Is a remote possibility. So அது வந்து நாலாவது இடத்துக்கு தள்ளிடும். So first possibility chronic malaria. Second one infectious. Can it be leptospirosis?
but the patient do not have history of fever.
Okay, then go to non-infectious cause. Non-infectious cause, can it be cirrhosis with the portal hypertension? Can it be hematological malignancy? Can it be non-hematological malignancy? First question, the portal hypertension, cirrhosis with portal hypertension. Can it be?
Yes.
What are the points?
The patient, he had history of upper GI bleed, which substantiates the presence of portal hypertension, and splenomegaly is also there. So he also had interest.
He dilated vein. What are the points favoring portal hypertension? Points against portal hypertension.
He is a young patient. He do not have history of alcohol or
Need not be Usel-Wilson disease, no? There is a possibility that may lead to cirrhosis, that may lead to portal hypertension, secondary portal hypertension. Is the portal hypertension now? Why? How?
out of 3 criteria needed, 2 are present.
Okay. So very same bleed with the splenomegaly. So in this case can be a portal hypertension. Okay. So our possibility is chronic cell liver disease, cirrhosis, portal hypertension. ரெண்டாவது ஃபிக்ஸ் பண்ணிக்கலாமா? Okay. Third possibility. Hematological malignancy. என்ன malignancy? Lymphomas, leukemias. Leukemias என்ன leukemias? ALL, CLL, CML, AML. Or lymphomas. Among the engaged. CML. Okay. So massive splenomegaly. Okay. In this case can be a case of CML. Alright. Then CML. What else you have to look in the history and in the examination.
The patient did not complain of easy fatigability, then joint pain,
body tenderness, any bleeding episodes, any ecchymosis, beta K, emaciation. This is not present in this patient. Okay. Still it can be a possibility. CML can be a possibility. Now order your differential diagnosis. 1, 2, 3, 4.
First differential diagnosis could be malaria. Second could
Chronic
be
malaria.
Chronic malaria, chronic liver disease with portal
Portal
hypertension.
hypertension.
Third could be CML.
Fourth, disseminated tuberculosis. These 4 possibilities are there. Then how do you roll out one by one in the examination, the investigation?
On doing
Doctor K. Frigi was there. See, naked examination. So he is subject to retinal examination. What are the investigations pertaining to Wilson's disease? Ceruloplasmin level, copper level. Okay.
There is family history, they do DNA analysis for mutation.
Finally, liver biopsy. That will confirm whether it is a Wilson's or not. Family history positive. What are the other features of Wilson's disease?
Manifestation,
Manifestation, symptoms, signs.
the patient can early presentation can be hepatic, similar to a chronic liver disease, and later, after 20 years, it could be neuropsychiatric manifestation with tremor, dystonia, presenting with dysarthria.
Emotional ability, right? Emotional, inappropriate emotion, that will be the first neuropsychiatric manifestation. Then seizure, tremor, dystonia, all these will be there. Okay, and then as you said, liver problem. So anything pertaining to liver cell problem. So these are the common features, right? So first decade, presentation will be in the first decade. Wilson disease, okay. Right, then other investigation, chronic malaria.
For chronic malaria, a peripheral smear we can perform and detect the presence of a plasmodium. And
Recent investigation,
Rapid
rapid test, rapid antigen test. Then anything else? Anything else? QVC, what is QVC? Right, so go and read. So all these 3 tests should be done for malaria. Right, identify the species and you have to treat. Right, okay, then.
chronic liver disease is border hypertension.
How will you confirm? As we already discussed so far. Ultrasonogram,
And
liver function test you can do. Then
malignancy. We'll do the smear and see for blast cells.
very good. Then you will confirm by bone marrow aspiration test. Again, there will be blast cell, increased amount of blast cells will be there. So you can confirm whether it is a hematologic malignancy or not. Right. Then.
Disseminated tuberculosis. So, tuberculosis sputum will do AFP staining, culture, and CBN or TrueNet.
CBN,
Chest X-ray.
just X-ray, serological test. Okay, right. So these will confirm whether it is a disseminated tuberculosis or not. Finally, you have to treat accordingly. Right. Wilson's disease, now what is the treatment?
Since the patient is having decompensated, it has progressed to decompensation level. They will give zinc and trientine. So zinc 50 milligram 3 times a day, and trientine 500 milligram 2 times a day. Within 2 years, the manifestations will get reversed. Manifestation of copper deposition, and this chelation therapy has to be given for lifelong.
Okay. Malaria, what is the treatment?
Malaria, anti-malarial.
What are the parental antimalarial drugs? Artemether, arteether, artesunate. Okay. So what is presumptive treatment? What is radical treatment? Really go for presumptive treatment. In the case of endemic malaria, on the day of taking smear, you have to give presumptive treatment. If the smear turns out to be positive, you should go for radical treatment. Okay. What is the treatment? What are the drugs used for radical treatment? Chloroquine, fluoroquine. So chloroquine is used for Receptive. Okay.